Chapter 27, Sensation, Perception, and Response. So again, I do not own this material. Under fair use, I'm providing lecture content for only my nursing students using this material. All content within is only for educational purposes for nursing students and does not provide medical advice. All right, so when we start talking about sensory systems, basically what you want to think about is when you walk in a patient's room, what do you see? What do you hear? What do you taste? What do you smell? What do you touch? Those are your five senses, and that's the way we bring in real-time information to our senses. So being able to see, hear, taste, smell, and touch. Super important for your own well-being, but also for the other patient as well. So the senses provide information about the internal environment and the external environment. And it helps us to experience the world. So the senses are allowing responses to changes. They help the body maintain homeostasis, and it's necessary for human growth and development. So some of the parts of a sensory experience. So there must be a stimulus and a receptor, right? So the stimulus sends out, the receptor is getting the message. So stimulus, think about the trigger that stimulates the receptor. So meaning depends on the reception and the processing. Loud noise, bright light, sour fruit, things like that. So the trigger that stimulates the response on the receptors. So sweet, sour, bitter, salty, those kind of things are extremely important to be able to monitor what's going on in the world. The reception is the process of receiving that stimuli from the nerve endings. So it occurs through the receptors, thermoreceptors, proprioreceptors, and photoreceptors. So look at this. Thermoreceptors, thermometer, temperature. So temperature regulation. Proprioceptors means you know where your arms and legs are, but you're not able to see them. So you know that you have your hands and feet close to your body or away from your body. Proprioception, the ability to tell where you are in space. Photoreceptors, think photo, light, images. So the perception is based on the ability to interpret those sensory impulses, give meaning to those impulses, and they can be affected by the location of the receptor, the number of receptors activated, the frequency of the action potentials, how many times they're being triggered, and then any changes in those things. So the location of the receptor, the further away, the closer it is, where is the receptor? Is it in the very bottom of your foot, or is it in your hand? Is it in your brain? Right? So those receptors and the number of receptors being activated are a big issue in sensory deprivation. So the brain, you remember this from A and P, but you need to remember these things. So frontal lobe, you hit your head, you wonder why your teenagers can't make a good decision, because they're not thinking with their frontal lobe. Frontal lobe decision making. Premotor motor area has to do with movement. General sensory area, sensory association area. The parietal lobe, the occipital back of your head, the visual association area, and the visual area back of the head. So back of the head, think about this. Whenever you see a picture of something in front of your eye, it's got to flip and go through your eye to the back of your brain and make sense out of it. So there's like a old movie screen in the back of your head. The auditory area right above the ear, the temporal area, the auditory association area right around the auditory area, and then the motor speech area. So how do we make sense out of the speech that we are providing? So arousal has to do with asleep, consciousness, alertness, things like that. So that's what you're going to be thinking about when you hear the word arousal. Arousal being mediated by the reticular activating system. So the reticular activating system is affected by environment and medications. Composed of consciousness and alertness, arousal. If you think about this, if you give somebody medication to make them sleepy, that's why they're affected by their medication. Their arousal may be affected by their environment if it's really, really loud, really a lot of lights, things like that. Okay? So some of those times that we give medication is so that they can go to sleep, so that they can turn that reticular activating system off. Responses to sensations, factors that affect response, intensity of the stimulus, the contrasting stimuli that you are seeing or having experience with, adaptation to stimuli, previous experience with stimuli, and it requires people to be alert and receptive to the stimulation. So, clicker question. Let's check in. The client who has a stroke states to the nurse, "You know, I can't even tell where my left leg is." This reflects lack of response to stimuli by the mechanoreceptors, proprioceptors, thermoreceptors, or chemoreceptors. Remember what I just said? They are not able to place where their right or left leg is. That is not mechano. Mechano would be movement. Thermo, temperature. And chemo would be chemical receptors. Chemical receptors are usually in your stomach or your brain. So think about this. It's going to be proprioception. Like I said, the proprioception. That enables you to understand where your position of your body is in space. So some of the sensory alterations that we hear a lot about in nursing is sensory deprivation, sensory overload, and sensory deficits. So sensory deprivation would be putting someone in a dark room, putting someone in a soundproof room. There's no senses coming in. Sensory overload, on the other hand, is like being in a hospital where there's so much noise, so much loudness, so many lights, blinking lights, beeping. That's sensory overload. Too many things coming in. And then you've got sensory deficits, which is there's a deficit in one of your senses. We heard a lot about that during COVID because a lot of people could not taste. So what's the downside of that? The downside of your senses being so overloaded is potential for seizures. So seizures, when we talk about seizure activity, we're talking about an abrupt onset of disturbance of electrical activity in the brain. And there's two main types. There's a primary generalized seizure, and then there's a partial seizure. Generalized, obviously, across the body, doesn't matter if it's right or left. Partial may be a certain part of the body being affected. So assessment, when you think about assessment, what are we asking these people? We're asking the nursing history, the physical exam, risk factors for impaired sensory perception. We're talking about mental status, their level of consciousness, Level of consciousness is person, place, and time. Environment, what in the environment is making this happen. And then also their support network. So some nursing diagnoses you may hear around this and the analysis of the data that is coming into you, you're thinking about acute confusion, chronic confusion, risk for dry eye, impaired memory, or unilateral neglect. So let's talk about these. Acute confusion. What kind of thoughts do you have about that? Acute versus chronic. Acute means it just happened. It's not a long-term issue. Acute confusion. Typical. Old lady comes in the ER, has a UTI, she's confused. Okay? As soon as we fix the UTI, she will no longer be confused. She will go back to her baseline. How do we fix the UTI? Put her on an antibiotic, give her some fluids. She'll be fine. Chronic confusion is something like dementia. Okay? That was a long time coming. It's not going to get better and it's not going to go away. The risk for dry eye, when we talk about that, that comes from their eyes potentially still being open, like during surgery, during procedures. So we really have to be careful about dry eye because there's a good chance that they're not able to sense that their eyes are dry, and we may end up with corneal abrasions, things like that. So whenever you have a patient that's unconscious, you always make sure that they have order for eye drops, eye ointment, whatever, to be able to keep those eyes moist. Impaired memory, that may be the beginning of some dementia. And then unilateral neglect. When we talk about unilateral neglect, we're usually talking about a stroke. So you know that strokes, if they affect the right side, they're going to affect the left side of the body, right? So the right side of the brain controls the left side of the body. The left side of the brain controls the right side of the body. So whenever you talk about which side of the body the stroke is on, remember that it's the opposite side that the affected brain tissue is on. So unilateral neglect means they only see one side of their body. They don't even realize they have that other side of their body. So when they go to get dressed in the morning, they will only dress one side of their body because that's all they know that they have. That's all they can see. They don't understand they have another side of their body. All right, so planning outcomes and evaluations, some examples of that. Effectively copes with excessive environmental stimuli, which means they don't get overwhelmed. Reports adequate sleep and rest. Nursing interventions for confused clients. Some of the nursing interventions that we would use, reorient them frequently. So you're constantly restating your name, the date, the time. Provide clocks and calendars. I want to make that clear that when you are in the ICU, there's usually not a clock, there's not a calendar. We're really having trouble, right? When we do wake up, we don't even know what time or date it is. Okay? Visual clues to time. Think about that. Visual clues would be turning on the lights during the day, turning off the lights at night. Keep things as normal as possible. And then use personal belongings. Bring in pictures of family members so that when they wake up, they realize where they are, who they are, what's going on, things like that. Typically what we will do, knowing that there's a chance for delirium in the ICU, delirium is a short-term but rather scary part of going into the ICU. When you wake up, you do not remember half of that stuff that happened. So what we will do is provide a journal so that the family members can go ahead and write what's happening, what day it is, things like that, so that they have something to go back and read so that they understand how long they were in the ICU. And then maintaining a safe environment. Communicate clearly and slowly, respond to feelings, use gestures. So when they wake up, they may be very startled. So respond to those feelings. Okay, you're all right. You're okay. You're at the hospital. So you're constantly talking to that patient to get them to understand that they're confused. We know that. We see that, and we're here to help them. Limit choices. This cannot be understated. If you ask them a question, you have to limit the choice. It's similar to like a toddler, right? You don't say what kind of juice do you want. You say apple or orange. That's it. Limit choices. Promote feelings of security. Make sure that they understand that they're safe. And then use alternative therapies. So a lot of the times they end up saying, oh, put them on this med and put them on that med. We really don't want to keep adding medications to patients like that. You would want to use alternative therapies. Continue to orient to reality. So this might be every 10 minutes having to reorient to reality. Confused patient level, altered level of consciousness patient is not going to be in the same reality. So you have to constantly reorient them. And then safety measures. Bed in low position, side rails up. So safety, safety, safety. Altered level of consciousness. Think head to toe. Do I care? We talked about that. Range of motion. If they're not conscious, you have to make sure that their joints do not get stiff. So you're constantly putting their joints through a range of motion. Is that passive or active? If they are moving, it's active. If we are moving them, it's passive. Skin care, mouth care, we're going to talk about that on Monday. Urinary drainage. So that if they're not able to get out of bed, we have to take care of that. We'll put in a Foley catheter. Bowel management. If they're unable to get out of bed, they're still going to be making bowel movements. So what do we do about that? Rectal tube. Nutrition. They still need to eat. They're unconscious. What are we going to do? Potential for a G tube, J tube, PEG tube, TPN, whatever. Okay? But you still need to feed them. If somebody's NPO for more than 3 days, it's time to call in the dietitian. No one should be NPO for that long. Let's talk about seizures. So nursing interventions for the client at risk of a seizure. Again, they're at risk of a seizure before, during, and after a seizure. So what kind of things do you think we do before a seizure? We're anticipating a seizure. We don't want them to seize without us being there and hit something. So make sure that padded side rails. During the seizure, turn them on their side so they don't choke, vomit, aspirate. And then after the seizure, we're giving them the medications to calm back down. Post-ictal, so after the seizure, they're going to wake up, they're going to be confused, they're not going to know what went on. So again, talking them through that. Lifestyle management. So lifestyle management with a seizure patient means that you encourage lifestyle management. Encourage them to get sufficient rest and a healthy diet. Advise them to avoid excess alcohol, and that their drugs that they take for the seizures may interact with that alcohol. So if somebody's on a seizure med, you're not supposed to be drinking alcohol. Advise the client to visit their primary care provider regularly. Why? Think about that. The medications may become too toxic, too much, or too little. Too much medication will make them stuporous, sleepy. Too little medication will continue to have seizures. So they need to have lab results drawn quite frequently. All right, click or check. So Mr. Arbor complains to the nurse that he's feeling anxious. He states, "I'm just so tired of all these tests they're doing, and it's so noisy here at night." His pulse is 110. His blood pressure is 140/70. Nursing actions should include which of the following? Turn on the television to provide distraction. Ask the client if he would like to discuss his anxiety further. Close the blinds, dim the lights, and ask the patient what other measures might help him rest. Call the physician in order for an anti-anxiety medication for PRN use. What do you think? Just thinking through this question. He's feeling anxious. He complains to you that he's feeling anxious. That's subjective. He is saying, "I'm anxious." He says, "I'm so tired. It's noisy." He's telling you he can't rest. His pulse is high. His blood pressure is high. What nursing action? Not medical, nursing action. Why would I turn on the TV? That's going to provide a distraction. It's not going to be a diversion. He's probably going to stay up watching TV. He's going to complain about more lights, more blinking, more noise. Why would you do that? The answer would be turn off the television. Ask the client if he'd like to discuss his anxiety further. He already has. Now it's time to go to action. Okay? So the answer is going to be C. Provide, dim the lights, provide the blinds. You might even go out to the desk and make a sign that says, "Please come to the desk. No entry," right? No visitors at this time. What he is asking you for is rest. Give it to him. You don't need an order for an anti-anxiety medication. Why put more medication on board? Some people actually respond opposite way to anti-anxiety medications. Why would you want to do that to him? Okay? So the most direct way to decrease the patient's sensory overload would be turn off the lights, put him to sleep. Safe and effective care. So the basis for effective, safe care is thinking, doing, and caring. So an older, frail woman is experiencing visual impairment resulting from glaucoma. Glaucoma is a eye issue. So if you don't know what glaucoma looks like, make sure that you take a little jaunder over to Vision Simulator online, and it will tell you the difference between cataracts, glaucoma, the whole gamut of all those. So how might the nurse show care and compassion when communicating with a client in the community setting? Just think about this. She's older, she's frail, visual impairment. In her home, you're visiting. As a visitor, what would you do for her? I would probably do an assessment of her house, make sure that she doesn't have trip rugs, make sure she has enough room to get around, make sure there's good lighting. Okay? How do you show care and compassion with communicating with her? Ask her. Literally ask her, "What can you see?" If she says shadows, that's not going to be very helpful, right? So you need to know if she can see the outsides or the inside in her sight. What would you want to do? Talk to her before touching her. She may get startled if she can't see you very well. Okay? Care, compassion. You're caring for a patient with poorly controlled type 2 diabetes. What physical complications would you expect? Impaired sensation to their feet and lower legs. Physical complications. Type 2 diabetes. What is that called when you can't feel or you feel pins and needles? There's a thing called diabetic neuropathy. Look it up. If they do feel their feet, it's pins and needles. Sometimes they're not even able to feel their feet. So if you think about this, what kind of shoes would be best for them to wear? Supportive shoes, not flip-flops. Okay? Flip-flops are not thick-soled. So if they were to step on a nail, if they were to step on a piece of glass, it's going to go right through the flip-flop. This is why people in Florida really need to wear shoes. Okay? Think about this. Most people will be wearing shoes or at least good socks, slippers, whatever. Well, there's a point in time where the type 2 diabetic might not be able to feel their feet and may not be able to get in shoes. So they may be wearing slippers around the house. Okay? If they go out to the mailbox and they step on a nail, what are they going to do? It's probably going to puncture. Okay? Flip-flops are the worst. Don't do it. Don't do it. So, for a patient with an altered level of consciousness, the Glasgow Coma Scale will help the nurse in planning. True or false? What is the Glasgow Coma Score? Anyone with a altered level of consciousness should have a Glasgow Coma Scale. If you get a test question on Glasgow Coma Scale, you want to know, is it getting better or worse? Okay? If it says that she's been 9 all shift and she's 3 now, that's a bad thing. Okay? If it's less than 8, intubate. If she's been 9 and she's 10 now, that's better. Okay? So you've got to know these things. Look up Glasgow Coma Scale, know it, understand it, appreciate it. It will be on the NCLEX, it will be on tests. So that is a true. The coma scale relates to the client's ability to function. As the score decreases, the client is less able to meet their basic needs, requiring greater nursing intervention. All right, so I want you to think about what you learned and describe how or why it's important to nursing, patient care, or sensory perception, each one of these. How is sensory stimulation important? How is sensory deficit important? What role does sensory overload play? Sensory aids and sensory deprivation.